Right, okay, so recording's going. So this is anemias and other bleeding disorders. A little bit more lighthearted than all of the hematological cancer stuff that we've been doing. So kind of a little bit happier to be teaching something that's not quite as morbid and like death and destruction based. Yeah, still can be pretty nasty. Generally, like not as difficult to get your head around as the leukemias and lymphomas and stuff, I think, but there's like, again, like a lot of little distinguishing factors between them. I haven't broken this one down into cases because for the most part, apart from like a few little things, your anemias all look the same. It's only when you get into your investigations and stuff that they're actually different. So what I've tried to just do instead is we'll talk about the specific bits that make them unique and the things that you should look out for in a particular case. And if it does prove to be something that's useful, one idea that I have thought about doing is trying to make some cases for you guys and getting them put out on the paramedics site that you can kind of work through and see if you've got your head around picking up those distinguishing factors that we've been talking about. Right. Let's get that shut down. So like to take you back to the basis of anemia, you need to think about how erythropoiesis works. So obviously it's happening in the bone marrow. It's stimulated by erythropoiesin, which is mostly produced in the kidneys, a little bit's produced in the liver, acting on bone marrow and encouraging those progenitor cells, those like precursors, to become dedicated erythroblasts. And we talk about erythrocytes being anuclear cells. They don't have a nucleus like all the other and quite a lot of the other cellular components. They lack as well, apart from mitochondria. But they like have these initially when they are in the bone marrow, and that's how they produce heme to begin with, and then they lose these. They get more and more condensed as they mature over a few days, and then they enter circulation as a mature erythrocyte and survive for about 120 days. And in an adult, most of your hemoglobin is made up of what we call adult hemoglobin, which consists of 2 alpha and 2 beta chains, and the rest of it is a variant known as HbA2 or some fetal hemoglobin, which if you think back to like probably a lot of like your embryology and fetal medicine that you might have done in first and second year, you'll know more about fetal hemoglobin from there. But we still have a little bit as adults. We just lose it a lot after about 3 to 6 months. And most of the breakdown of your red blood cells occurs in your bone marrow, your liver and your spleen, which if it's broken down that way, we call it extravascular hemolysis, because it's occurring in the organs that make up your reticular endothelial system, or it can happen in the intravascular in circulation. And both of these types of hemolysis present a little bit differently, which we'll get on to talking about later on. But the thing to remember is like when you're getting any kind of red blood cell breakdown, because the heme's getting broken up, you're going to get this release of bilirubin as well, and it can be a cause of prehepatic jaundice. So if you've done your jaundices to death, you'll know like about that cycle of bilirubin breakdown and conjugation, unconjugated, etc. That kind of comes into play a little bit here too. So when you're specifically looking at anemias, there's a lot of different things that we look for in terms of like you might consider B12, iron studies, etc. But the main things we're looking at initially in investigation is your red cell indices. There's a lot of different letters. They get quite confusing. The main one to focus on is your MCV. So just to go over them, you've got MCH, or mean corpuscular hemoglobin, which is how much hemoglobin you've got in a single red blood cell. Your mean corpuscular volume, which is an indicator of the size of red blood cells. So you can be microcytic, normocytic, or macrocytic, which is how we divide the anemias, which we'll be going into. And you can get mean corpuscular hemoglobin concentration, which is how much hemoglobin is there in a single like unit volume. Not it takes into account the volume, whereas like your MCH doesn't, but generally it's the MCV that we're going to focus on. So just to kind of, if you see those words, just to kind of break down what they mean to you. So what is anemia? It's important not to think of anemia as like an end stage diagnosis. It's always happening secondary to something. It's a sign, but that's not to say that we don't still talk about it in like disease classification, but you'd never just diagnose someone with anemia. And And generally it's the term that we give to having a low hemoglobin count for your age and your sex. So it's a little bit higher for men, tends to be about 135 is your cutoff. For women, it's about 110, but you can get like normal person to person variation. Some people just naturally have a much lower count. And it's generally when it's about below 70, we talk about that being the cutoff where transfusion is needed. And your like principal causes, your rough causes, if you want to group other causes into things, are due to low red cell mass, increased plasma volume, such as what you see with pregnancy, reduced production, or increased loss of red blood cells like you get with hemolysis. And we divide it into 3 types. Hyperchromic, microcytic. The hyperchromic bit's just referring to the fact that for the most part, like they're pale, they're lacking colour, such as like they get from like having iron in them. A normochromic, normocytic anemia, or a macrocytic, which we can divide into megaloblastic, which is where something has gone wrong with DNA synthesis, and that results in this like big unfolded, like these big unfolded nuclei within your red blood cells, so they're a lot bigger than they should be, or non-megaloblastic. And if we're going to distinguish type, obviously they're all presenting kind of similarly. We need to obviously do your history, examination, and blood film. Blood film tends to be like the key one. And then if you're then confused from the blood film between a few types, that's where you break it down with stuff like hemoglobin electrophoresis and other things like that. I think a few people have joined a little bit late, but hopefully you've not really missed much because we've not gone into any types yet, so cool. So symptoms of anemia. So as I was saying on the last slide, anemia itself is a sign of things. You can say this patient with whatever underlying condition is positive for anemia, for instance. But generally you're getting those symptoms that are relating to the fact that obviously hemoglobin is what we use to carry oxygen around with the red blood cells. If we're lacking that, you're going to have symptoms relating to that. So tiredness, shortness of breath, especially on exertion. So very often your patient can be well when they're just like sitting, as I'm doing. And the minute they try and do any kind of activity that's going to have increased demand, they notice it with shortness of breath and things like that. Palpitations, feeling dizzy, headaches, tinnitus, again, all things just relating to that like lack of blood flow. Having low blood pressure can be one as well, because it tends to like occur concomitantly with hypovolemia in a lot of cases. And anyone that's got a pre-existing cardiorespiratory problem, so someone who's already got acute coronary syndrome, something like that, angina and things like that can get worse, or they can get all these like flow murmurs and things like that. And signs, obviously pallor, cold extremities, and what we call hyperdynamic circulation, which is where, because you've got this reduced volume, you get compensatory mechanisms such as like your heart rate's going to shoot up, and the heart gets bigger because it's trying to make up for that lack of oxygen, not meeting the demands the rest of the body has. And in hemolytic disease, some conditions, when you read them in textbooks, they'll talk about anemia that presents with lemon tinged skin, and all that is just pallor that's coming from the anemia overlaying the like mixed in with jaundice that you're getting from that bilirubin breakdown that's giving your patient that beautiful yellow skin that they get. And splenic enlargement sometimes occurs as well if you've got extravascular hemolysis, because you get an increased breakdown of red blood cells within the spleen. It's working over time, it swells, it's going to get bigger. Cool. So just to investigate it broadly, how we're going to investigate all anemias, like we said before, history and examination of all relevant symptoms. So don't just look at them and think, okay, are they pale? Have they got angular stomatitis or conjunctival pallor or whatever? Am I going to look at the abdomen to see the splenomegaly, investigate for potentially an underlying leukemia that could be causing it with neck examination, things like that. Full blood count, determine, okay, is it just the red cells that are low, for instance? Iron studies, because iron deficiency is 9 times out of 10, that's going to be your cause. Serum B12 and folate, bilirubin, LDH, haptoglobin, they tend to be raised if we're looking at a hemolytic cause. Direct Coombs test, that's testing to see if we've got autoantibodies within the blood, and it's going to be positive if we've got an autoimmune cause of hemolysis or something like that. Blood film, if you've got quite a benign cause of your anemia, so something that's quite common like iron deficiency, and it's like absolutely barn door on the full blood count or the iron studies, you're not going to go so far necessarily as to have to do a blood film or bone marrow aspirate, which is like the next one we'll talk about. But these are more for like your cases where they're like a bit more harder to distinguish what's going on. So yeah, you might do blood film to see what morphologies you've got. Have you got any spherocytes or weird like Heinz cells, things like that, which again wouldn't like worry too much about the definition of. Do a bone marrow aspirate if you're thinking, okay, is there anything a little bit sinister maybe going on? And you may, I've included some terms here that you might again read about in textbooks and stuff, which to me never make sense until they're explained. So if you see something that says a sample had dimorphic cells, that just means that there's at least 2 populations being seen, and you only get at least 2 populations if there's like 2 concurrent pathologies going on. So it could be that you've got a patient who's got iron deficiency and also has B12 deficiency, and you would pick that up based on what you see in the aspirate. If you see the word poikilocytosis, that just means the cells are really weird shape, but generally like are uniformly weirdly shaped. And anisocytosis means that they're unequally sized, so you might have some big ones, some small ones. It could refer to, for instance, you having a few megaloblastic cells and some normal ones, or some reticulocytes, which was your bigger as well, and some normal ones. In cases where you've got haemoglobinopathies, so things like thalassaemia and sickle cell, consider electrophoresis, and enzyme assays where you've got particularly the enzymes that you need in metabolism of red blood cells, so G6PD, pyruvate kinase. You do an enzyme assay just to see what the activity levels were like on those. Cool. Yeah, so breaking them up into causes, again, going back to your MCV, you'll see this like different textbooks will kind of put some in different places, and that just tends to happen when you've got certain causes like anemia of chronic disease, where sometimes it can be one, sometimes it can be the other, but one textbook will say religiously it goes in that one, religiously it goes in another. So yeah, if it's kind of confusing you a little bit because you're trying to categorize them a lot generally, and you're seeing it in like in the multiple places but put in different boxes, just accept that it could just have it could be microcytic or normocytic sometimes, it could be macrocytic or normocytic sometimes. Like they're not always all bundle. So microcytic causes iron deficiency, thalassaemia, sideroblastic, sometimes anemia of chronic disease. In normocytic, these tend to be the ones where like we're not really going to, apart from anemia of chronic disease, we're not really going to go over any of these because again they're all like, apart from hemolysis, they're all like separate issues that will just cause a normocytic anemia as a byproduct. So like blood loss, bone marrow failure, hypothyroidism, stuff like that. And macrocytic, again, the one we divide into megaloblastic, which is always usually B12 or folate, and then non-megaloblastic is pretty much everything else causing big cells. And generally they're causing big cells again because they're still interfering with the way it's produced, but not necessarily like the DNA production side of things. So I've labelled there that anemia of chronic disease is one of the weird ones, which can be microcytic or normocytic. And hemolytic anemias can be generally normocytic or macrocytic as well, but it's not then that you'd kind of distinguish what's going on by the MCV. You'd be looking for things like the raised haptoglobulin, the bilirubin, the LDH, and those signs of prehepatic jaundice as well. Cool. Iron deficiency anemia. So yeah, just to clarify, a lot of the early stuff we're talking about is the common stuff. So you might be sitting there thinking, yeah, I know what that is, move on, it's fine, but we'll work through the weird, the common stuff to get to like the more weird and wonderful stuff. So please bear with me. Yeah, iron deficiency anemia is like your most common cause, and it affects something like about 30% of the world's population. Most commonly it's affecting menstruating women because naturally we, you know, tendency to bleed, you lose iron, it's not getting made up for in dietary sources and things like that. And we take iron in generally best taken in the heme form, which is consumed through animal products, also available in a non-heme form through like plants, cereals, pulses and things like that, but we don't absorb it quite as well in that state. And it can also be ferrous or ferric, and we absorb the ferrous form of it better. So just because you're getting iron doesn't mean it's in a form that's easy to easy to take in, and stuff like having really high phosphate levels, your gastric pH being a bit off, or drinking a lot of tea because it contains tannins can upset how easy it is for you to absorb iron as well. So just because you're getting enough of it doesn't mean that the rest of your diet is making it easy to consume either. So yeah, a couple of things, like if you're not too familiar with like how iron is transported and stuff like that, it kind of helps just have a bit of a background idea of it. So yeah, it's transported, bound to a molecule known as transferrin, which is why we look at transferrin when we're trying to see, like look at an iron studies to see what's going on and see how occupied those are. And about 2/3 of the iron in our bodies is stored in red blood cells as heme, but some of it's stored in this insoluble form known as hemosiderin. So you'll see things in certain conditions called hemosiderin deposits, and that's just like excess iron that can't be stored in red blood cells or anywhere else, depositing in usually like in the heart and the lungs and then like endocrine tissues particularly, and it's insoluble, so yeah, we struggle to break it down and get rid of it on our own. And causes, yeah, most of the time we're not taking enough in, we are having to produce more, so for instance pregnant women, and we can't meet demands from what we're taking, states of malabsorption, so like celiac disease, Crohn's, ulcerative colitis, or what's one I'm thinking of, yeah, I've said dietary already, pregnancy and malignancy. It can happen quite a lot in that as well. Just a key thing to remember though is, so ferritin is one of the ways that we kind of measure it, because that's like one of the ways it is in the body, but you can have a high ferritin because ferritin is also an acute phase protein. So if you've got something like malignancy going on when there's inflammation, your ferritin might actually be really high because you've got this inflammation that's concurrent, and it's sort of masking the iron deficiency. So don't always assume that like your iron studies are going to be barned or if there's an underlying cause. So yeah, generally if it's not a young menstruating woman who's presenting with iron deficiency anemia, you've got to think, could there be something else a little bit more sinister going on? So any women that aren't actively menstruating or are menopausal, or any men who present with any kind of anemia and it's coming back on your studies as though it looks like it's iron deficiency, send them off for like colonoscopy, gastroscopy and stuff like that, because you've got to think, could there be something else going on here? So yeah, on your iron studies, generally low ferritin unless there's some kind of inflammation going on. You'll have low serum iron and low total iron binding capacity because your transferrin is like, it's empty. It's sorry, that should be high, TIBC, I need to change that. Yeah, you've got high because it has the capacity to bind to a lot of iron, but there isn't any iron there to bind. So to manage it, if your patient if it's just a simple dietary thing, encourage them to take oral iron. So I think it's usually like ferrous sulfate that we give. If there's a problem with absorption, then consider using it IV. And generally what you want to see is an increase of about 10 grams per litre a week, and you're going to continue it for at least 3 months after it's normalised. Thing to remember with iron tablets is them themselves can cause side effects. So your patient might complain of having really dark stools and constipation, abdominal discomfort and stuff like that, but generally like they usually quite well tolerated side effects anyway. There's a lot of key signs and symptoms that we get taught to look for on OSCE, but very often like you're never really going to see them because most people with iron deficiency, it's picked up quite quickly because they come in complaining of fatigue and then they start taking supplements. So threw some pictures in just in case you didn't know what they look like. So atrophic glossitis, that's just like swelling of the tongue, and it's a global thing as well. It doesn't tend to be patchy. Koilonychia, spooning of the nails, sounds weird. Again, like not very common to see, but it is quite obvious. And the like, what's the word I'm looking for? Chelosis, I think it is. Bear with me a second. Yeah, angular chelosis that you get around the lips and stuff. It can look a little bit like they've got some sort of infection going on, but it just looks like a very dry mouth around the edges. Things look very cracked. You can get this weird thing called Plummer-Vinson syndrome. So if you get an exam question where it talks about a patient who is presenting with iron deficiency anemia, but they're also having trouble swallowing stuff. And you do studies and you see webs in the esophagus. It could be this thing called Plummer-Vinson syndrome, which is this very rare syndrome that they seem to sometimes love in exam questions. Typically happens to perimenopausal women where they get dysphagia, esophageal webs, iron deficiency anemia, and that's like the classic triad of it. And you just manage it the same, so like iron supplementation, and you might need to go in and mechanically widen the esophagus to cope with the dysphagia. Only thing to bear in mind with this is that there is a slight increased risk of squamous cell carcinoma of the esophagus, so you'd probably just consider monitoring these patients. Anemia of chronic disease is like the most wonderfully vague diagnosis ever, but it is the second commonest cause after iron deficiency, and if you're looking at hospital patients particularly, it's the most common cause in that setting. So it tends to happen because you've got iron isn't getting used well, you've got cytokine-induced shortening of red blood cell survival span because you've got this inflammatory state going on, or you are producing the erythropoietin but your bone marrow for whatever reason just isn't responding well. And I've put this thing about hepcidin being implicated. We don't really understand why. The research behind anemia of chronic disease is still very inconclusive, but it just explains why we can use hepcidin inhibitors as part of the treatment for it if other things don't work first. So you tend to get it with chronic infections, so things like TB, HIV, vasculitis, rheumatoid arthritis, and malignancies. And it's not generally the name that we give to anemias that are caused secondary to hemolysis, bone marrow infiltration, because they themselves are due to a different pathology. You don't tend to see a lot of iron in the developing progenitors because it's just the whole process just isn't happening as it should, but very often you will get iron deficiency anemia as well. And yeah, so like we said before, it can be normocytic or microcytic. Your iron is low and you've got reduced total iron binding capacity because your iron is kind of there, it's just not it's not that it's not bound to transferring per se, it's just not getting put into the red blood cells as it should be doing. So your main treatment of it is just treat the underlying disease. You might find it useful to use erythropoietin or give IV iron, and hepcidin inhibitors or inflammatory modulators might be useful as well. But yeah, again, this is a bit of a weird one, and I know a lot of the information in it seems kind of contradictory, and that's just because it can occur in secondary to so many different things, and it can look very different as well. But generally, if you've got a case where you've got a patient that's got an underlying rheumatoid arthritis, they're quite old, they've been in hospital, and this is one of your options, and you've got that reduced total iron binding capacity as opposed to an increased iron binding capacity, total iron binding capacity, it's more likely it will be this one than the other. So sideroblastic anemia, one of your rarer ones, but it still kind of deserves a mention. So you've got enough iron, you just can't make effective use of it. So what you end up getting is these rings of iron around the mitochondria of the cell, these hemosiderin deposits everywhere, and they give the cell this characteristic ring, which is where the anemia gets its name from. Doesn't really present very differently to other anemias, but it tends to present with what you call a refractory anemia, which is where you get this quite persistent advanced anemia that you need a lot of blood transfusions to treat. So it tends to be a lot more aggressive semen than, say, iron deficiency or anemia of chronic disease. Classically, it's going to be microcytic, hyperchromic. Ferritin's probably raised because you might have, you've got excess iron going on, and you're going to get these characteristic sideroblasts in the marrow. And to treat it, remove the underlying cause, because it can be either X-linked or it can be linked to loads of different acquired causes. So it could be alcohol excess, rheumatoid arthritis, hematological cancers. The general rule with most of the anemias, to be honest, is if there's not a distinct underlying cause, then it can be secondary to so many things. So yeah, and because again, this is quite a transfusion dependent one, because it tends to be present quite badly, you can use a drug called pyridoxine, and you may want to consider repeated transfusions as well. So moving on to megaloblastic ones. So megaloblastic, again, is just where you've got It's a macrocytic, but if you've got megaloblasts, it's just these red blood cells that have got like basically dodgy DNA, which is causing them to be really big. And it's either B12 or it's folate. So more often than not, it's B12 related. And you have about 2 years worth of stores in your body. You store about 2 to 3 milligrams of it in your liver. So it can take a long time before this appears. So it tends to be like, say, if it's secondary to someone that's had a bowel resection, it's probably going to be a few years before they present with this. They tend to love exam questions where they go, a vegan patient presents with anemia. It's not to say that all vegans are going to have B12 deficiency, but it's just because your sources of B12 are naturally everything but plants, which is like in the cheesy little picture that we included in the slides up there for you. So yeah, tends to occur in vegans. Pernicious anemia actually is the most common cause, which we're going to talk about on the next slide. People who've had gastrectomies, because that's just going to, obviously you release intrinsic factor from your stomach, so no intrinsic factor, you're not going to be able to absorb B12. Ileal resection, because you absorb B12 in your terminal ileum when it's bound to cobalamin. Tropical spruce, certain diseases can reduce your ability to absorb it as well. And nitrous oxide can, if I mind myself, it deactivates it. Fun fact of the day. I've never had that in a question before, but you never know. And ways of differentiating it when you've got that, when you've narrowed it down to being a megaloblastic anemia, you're going to look at your serum B12, that should be reduced. Holotranscobalamin is something else you can look at, but you don't tend to do it routinely. And also intrinsic factor antibodies, they are specific for pernicious anemia. Not everybody will have them, but you're probably going to look at them as well to see if that could be your underlying cause. And you treat it generally by giving hydroxycobalamin, IM, on like alternate days for about, I think it's 2 to 4 weeks. Let me see. I'm going to say 2 to 4 weeks. Yeah, for about 2 weeks. And then you're going to give it about every 3 months for the rest of your life, because you can get quite a lot of nasty side effects from B12 deficiency. So you're not going to want to let that one slip. So pernicious anemia, that's autoimmune atrophic gastritis. You lose those parietal cells, which, if you think back to first year stuff, they secrete your H+ ions and intrinsic factor. No intrinsic factor, you're not going to be able to. There's a long pathway. Again, I've got it in the handout notes, but if you really want to know, it's there. But no intrinsic factor, no absorption of B12. Tends to affect older women. There's a bit of a link to like blood group A, but again, like that would be quite a mean exam question for them to go, oh, there's this patient that has blood group A. And typically occurs with other autoimmune conditions as well, as anything that is triggered by autoantibodies is going to be. And most patients tend to have parietal cell antibodies. These aren't specific to pernicious anemia. I think there's something like about 10% of people have them anyway. But in about 50% of pernicious anemia cases, patients will have intrinsic factor antibodies, and they are specific for the condition. So generally, again, you treat it exactly the same as you would for B12 deficiency caused by dietary losses or ileal resection or whatever. But there is a small percentage, like a 1 to 2% increase of gastric carcinomas. So you're going to want to monitor these patients for those symptoms as well. So when we're talking about the nasty side effects you can get from B12 deficiency, you may have heard of this thing called subacute combined degeneration of the cord, which for whatever reason, if you have a long-standing B12 deficiency, you can get this demyelination on the dorsal column. And it's reversible early on, but the longer you leave it, the less reversible it's going to be. So it tends to just start out with your patient who might be a little bit like showing signs of being a bit depressed, or they've got tingling in the fingers or something like that. But yeah, their pressure vibration will start to diminish. They start to get ataxia, stiffness, and all these kind of like a mixture of low motor and upper motor neuron signs. So positive Babinski, or like toe jerk, positive Romberg sign, absent knee jerks and ankle jerks. And yeah, you just give B12 supplementation, so you can sort it with that if like it usually improves within like the first like 3 to 6 months, but the cord signs, once you've got them, you're generally not going to get rid of them. So like if you suspect B12 deficiency, don't delay. And yeah, folate deficiency. So another thing with these two is they tend to occur together quite a lot, because if patients are lacking in one dietary thing, or their absorption's poor in one way, it's probably going to be poor with the other one as well. So with folate, you only have about 4 months worth of supplies, and we tend to take them in from like cereals, leafy greens, things like that. And you absorb it in the proximal jejunum or duodenum. So sometimes an exam question, like all it will give you to go off is the specific bit of the bowel that's been resected. So just try and remember which is absorbed in which, and that can kind of be the thing that tips between it being folate or B12. And very often they might even say, okay, you've got both as an option. You've got to kind of look at the blood results you've been given and be able to work that out. So causes can just be like inability to take it in well. So it could be that you've got an old patient, someone who's alcoholic, they're isolated, someone who can't absorb it well because they've got an underlying cancer or inflammatory bowel condition, antifolate drugs, phenytoin, methotrexate, trimethoprim, your main ones, or states of increased cell turnover like hemolysis, pregnancy, renal dialysis, things like that. So you're always going to want to assess for an underlying like GI pathology, like a malignancy or something like that, and get the serum folate levels, but also like make sure you still get those B12 levels as well. Because if you start treating a folate deficiency that's actually been masking a B12 deficiency as well, you can just kind of accelerate the rate at which that subacute decombined degeneration occurs. So a lot of the time you'll give both folate supplements, which you would just continue for 4 months to replenish those stocks. There's no need to continue this for life, but you'll give B12 as well, just kind of like prophylactically. And obviously, like, we're not going into the obstetrics and gynecology side of stuff here, but it's important to be counselling women about it in pregnancy with like the neural tube defects and stuff like that. Non-megaloblastic. So we're saying mostly this is caused by stuff that's like alcohol and things that I'm not going to dedicate a slide to, but there's a few kind of rarer ones that are worth a mention. So aplastic anemia is probably the main one. And aplastic anemia is this kind of pancytopenia, which is from your count of those pluripotent stem cells in your bone marrow being cut down. So most of the time it's just idiopathic. We don't really know what's caused it, or it can be part of syndromes such as Fanconi's anemia, or you can get it as a secondary, like a cytotoxic side effect of things like sniffing glue, chemical exposure to benzenes, industrial exposure, ionizing radiations, long-term infections like HIV and TB, this thing called paroxysmal nocturnal hemoglobinuria, which is where you have hemolysis that for whatever reason leads to you sort of just having hemoglobinuria, especially like at night and in the morning. I've stuck it in the handout, but I just thought it's not what I'm going to give a whole slide to, because it is a bit of a weird and wonderful one that, again, if you want to read about it, it's there for you to do so. So initially you will just present with bleeding, and that can be anything ranging from like ecchymosis to like bleeding at like IV sites and stuff, anemia and infections, particularly like mouth infections like candida and stuff like that. So on investigation, your full blood count is going to show a pancytopenia. You're not going to have any reticulocytes because you're not able to regenerate those little precursor cells, and your bone marrow sample is going to show that it looks hypocellular, and there's increased fat spaces because you're just lacking cells to make up the bone marrow. So treat any underlying causes, consider transfusion if you've got the need to, if your patient's hemoglobin's low enough. You might be able to consider stem cell transplant if you've got a suitable candidate, but again, that kind of therapy's got like really high mortality, and you need a suitable HLA donor as well. And you can consider immunosuppressive therapy if that's just not an option for your patient. So hemolytic anemias, there's quite a few of these to go through, but they're also like, again, few fun ways to kind of like differentiate them, because they can just present with just patient has an increased bleeding tendency, patient has prehepatic jaundice. So normally they're going to have a normal or a raised MCV, they'll be normocytic or macrocytic. You're going to have unconjugated bilirubin, leading to this prehepatic jaundice picture, where obviously you're going to get the yellowing of the skin, but you're not going to get like if I'm remembering this the right way around, your associated changes in your urine and your stools. LDH raised because you've got increased cell turnover, more reticulocytes, polychromasia. That's just meaning that we've got like more like of a range of like colours in your cells because you've got a bigger range of cells at different ages. So like precursors through to like mature erythrocytes. If it's an immune cause, so if it's autoimmune, if it's the autoimmune hemolytic anemia, your direct Hume's test will be positive because you'll have autoantibodies against your red blood cells in your circulation. I've not included this on every slide because I just thought it was a bit repetitive, but with most of these, for whatever reason, you get leg ulcers and you get increased pigment gallstones because you've got that extra bilirubin in circulation. So that can often be like a presented complaint for patients as well. And in the ones where it's particularly severe, because your bone marrow can kind of like, it can expand by up to about 3 to 6 times to compensate for like the hemolysis that's going on. You get this bony expansion and extramedullary hematopoiesis as well. So you can get, particularly with thalassaemia, which I'll show you some pictures of in a bit, you get this bony expansion that's like quite characteristic. Hereditary spherocytosis, that's like your most common one. And if you can think back to when I was talking about the difference between intravascular and extravascular hemolysis back at the start, this one presents with extravascular hemolysis. So extravascular just meaning that the hemolysis is taking place in the reticular endothelial system. The main difference between them just tends to be you get splenomegaly with extravascular. At least like that's the main way that I remember it, because it's mostly going to happen in the spleen. But that is just a little factor that helps you differentiate it between this and G6PD, which is another common one, which we'll go on to in a minute. So yeah, mostly happens in people living in Northern Europe, and it's to do with like these autosomally dominant inherited defects in red blood cell membranes. So when they're passing through the spleen, they get destroyed because the macrophages are picking up on them that something's not right. And it can normally present with this jaundice at birth, but it can be delayed and not present quite that early on. And you end up with aplastic anemia or megaloblastic crisis, especially when you've got infections. And like the key infection that's going to cause problems in hemolytic anemias, we talk about it usually with sickle cell, but it can happen with most of the hemolytic anemias because it's an erythrocytic's not the right word, but it attacks red blood cells, is parvovirus B19. So if you get an infection with parvovirus B19 in hereditary spherocytosis, you might be quite asymptomatic and then present with like a period of anemia, and splenomegaly as well because it's an extravascular hemolytic disorder. So in your investigations, if you do a blood film, you might notice spherocytes and your direct Hume's test will be negative because there's no autoantibodies. It's to do with a membrane defect instead. So you may find that splenectomy relieves some symptoms and reverse growth failure, because remember this is most commonly presented in childhood or like if not from the neonatal period, and it might also prevent gallstones as well. So G6PD. So this is an enzyme deficiency that is basically resulting in the red blood cell not being able to metabolize easily, can't make ADP and things like that. So it's not able to have the antioxidant effects that it should have, and then it's more prone to oxidative crises. So it doesn't tend to affect Europeans as much. It's more in like Africa, the Mediterranean, Middle East, Southeast Asia. So again, if you're looking at like a typical case scenario, in certain questions, they might like to use the patient's ethnicity as a distinguishing factor. And it's carried on the X chromosome as well. So it's going to be males who are affected unless you've got females that have like random inactivation of chromosomes. And these oxidative crises that lead to like a very rapid anemia and jaundice, they can happen because the patient's used henna, they've ingested fava beans, or they've taken certain drugs. But most of the time, patients tend to be completely normal between attacks. So if you took a blood sample while they were fine, they'd look absolutely like as like a normal person should do. And you might have, during an attack, evidence of hemolysis, these things called bite or blister cells or Heinz bodies, which are just cells that don't look as they should, I wouldn't worry too much about what they're specific to, because they can occur with a few different things, or again about what they look like. And you can take a G6PD assay to look for like enzymatic activity, and see, obviously if it's low, you're thinking we're deficient. So for the most part, if patients are okay between attacks and they know they've got it, you're just going to kind of educate them about what the precipitants are, tell them to avoid those. If they've got underlying infections, treat them when they get them to try and avoid anemia from occurring in the first place. If it gets severe, treat them with blood transfusions, which you might be picking up as quite a theme with anemia. So telling the difference, if you've been working hard on past med, which you probably have been doing, you've probably seen this one already. So again, just remembering, like, you've got intravascular hemolysis with G6PD, extravascular with hereditary spherocytosis, autosomal dominant on hereditary spherocytosis, X-linked recessive on G6PD, but they can both present with neonatal jaundice, gallstones, infection leading to hemolysis. So like, use the ethnicity, use the gender, use things like is the splenomegaly present as your distinguishing factor between the two, if it comes down to those being an option on the multiple choice question. Pyruvate kinase deficiency, you're a lot less likely to come across this, but it's another one of the metabolism defects like G6PD. Since there are millions of people, it's going to just affect thousands. Also presents with an extravascular hemolysis as well, so you do get splenomegaly, and you might get these things called prickle cells in your bone in your aspirate, and generally like kind of similar management to like a combination of the two. So transfusions if they need it, splenectomy might help with symptoms again, but again, wouldn't worry too much about that one. Your autoimmune hemolytic anemias. So when we were talking about the Coombs test before, this is the one where it's going to be positive. So that's why you'd want to consider running that to kind of, when you've got signs of hemolysis, if you want to pick out that it's going to be autoimmune, direct Coombs test should be positive. And if you've got a patient that's got other autoimmune conditions anyway, so generally like SLE probably being the most common one, and then you more think that this could be a cause as well. So it's just where your autoantibodies are destroying your red blood cells. It tends to happen in your extravascular system, in your reticular endothelial system, so it's extravascular. We split it up into two types. Again, like, there's not really like, you can really read into why it happens and like the mechanics of what's happening at the cellular level, but just generally remember, like, the warm type's happening at roughly room temperature. It's IgG predominant, tends to happen in middle-aged females, and you have this relapsing remitting pattern of them being absolutely fine and then having these attacks if they've, for instance, gone into folate deficiency or infection. And you'd manage it with kind of steroids just to immunosuppress, or stronger immunosuppressants, and you consider splenectomy if the symptoms are getting particularly bad. And your cold type happens at about 4 degrees or less. It's IgM predominant, and your patient might present with Raynaud's phenomenon or acrocyanosis, which is where you get like a more permanent like discoloration of the extremities. And you're just going to basically tell your patient, keep warm, avoid the precipitants. A drug called chlorambucil might help if they're getting symptoms quite a lot, but otherwise you wouldn't tend to medicate it. This one's quite a hard one to give transfusions to, because obviously a transfusion is coming from a donor, and there's all, like, I've written about this in the other handout that I've done for you. Actually, there's quite a lot on blood transfusions in there, and like the different things that can go wrong, because that's probably like a whole presentation of its own. But if you've got autoantibodies anyway to your own blood, it's more likely you're going to get them to donor blood. So yeah, these ones aren't the easiest to kind of treat if they get quite bad, but luckily they don't tend to get that bad. Hemoglobinopathies, it's a word that we tend to use to refer to thalassaemia and sickle cell. So in thalassaemia, you've got these defective globin chains being produced. They tend to precipitate within the cells. So then not only like are you producing these cells that don't have the right type of hemoglobin necessarily to carry oxygen, and you've got anemia from that, the cells are kind of dodgy and then they get destroyed through hemolysis anyway. So it's kind of like a bit of a double whammy of what's going on. Your most common one's beta thalassaemia. So it's due to point mutations on chromosome 11. So you're going to have more, that should be HbA2, more HbA2, more of your fetal hemoglobin, and maybe a little bit of adult hemoglobin. It depends kind of like where you are in the phenotype. So some people might be heterogeneous for it. or be what you call beta thalassemia minor or beta thalassemia trait. And this is a carrier state where generally they're asymptomatic or just have mild anemia, and it might get a bit worse in pregnancy when that demand goes up anyway. They might have intermedia. Again, it can be like a variable, different levels of mutation in this, but this is more kind of referring to like the intermediate just being like the symptom level, I guess. And they're going to have a moderate anemia, but there's not going to be a transfusion requirement. That's the thing that makes it intermediate and not major. If they are beta thalassemia major, they've got like these significant abnormalities. They're likely to present with failure to thrive after about 3 to 6 months when their HbF production falls, probably going to have hepatosplenomegaly, and might have bony expansion, but this would only be in patients that aren't treated. So to treat it, you're going to be basically having blood transfusions for the rest of your life, about once, twice a month, because there's this risk of iron overload from the hemolysis releasing iron. There's a risk of hemosiderosis. So consider giving desferrioxamine, which is an iron binder, on an chelator. And you might want to give hormone treatment as well, because you can get these iron deposits in your endocrine organs. You can present with like hypogonadism, hypothyroidism, stuff like that. So obviously treat those if they present as you would for those conditions anyway. So we were talking about the characteristic bony issues that you can get with this. So again, this is like a really extreme case, the kid who you can see over on the right, but obviously he exists, so it can happen. And it's just because you get this extramedullary hematopoiesis, so you get frontal bossing, for whatever reason the nose shrinks in, and like your long bones, like they become a little bit more like trabeculated and porous, and they don't grow as well because, again, like their energy is just, they're committing more to producing red blood cells than they are to, say, growing properly, and you get this failure to thrive that comes with that. And you get this thing, the picture hasn't really showed it very well, annoyingly, but you get this thing called hair on end sign, which it kind of just looks like you've got like lots of little spikes coming out of the skull on X-ray, and it's just because you've got these like cortical expansion, but it's all like very porous and thin, so it looks like little hairs that are standing up. Alpha thalassemia. So there are 4 different genes on chromosome 16 that can code for your alpha chains. So if you've got 4 genes deleted, you get something called HB Barts. Your patient, they might live a little bit, or they're going to be stillborn. They present with this thing called hydrops fetalis, where you get like ascites, abdominal swelling, stuff like that. I'll just find my thing again, because there's a few points of what it's got. Thalassemia. Yeah, pale edematous and have enormous hepatosplenomegaly. So these kids, because HB Barts can't carry oxygen at all, they're not going to survive, unfortunately. If you've got 3 gene deletion, you have what's called HBH disease. You might have this moderate anemia. You might have splenomegaly, but you're not going to be transfusion dependent. So it's a bit like it's the intermediate state again. 2 gene deletion is alpha thalassemia trait, and 1 gene deletion, generally, like, you're never actually even going to notice it, but it is possible. Sickle cell disease, so like the last one, then we're done. So sickle cell is, it's quite bad. You tend to see it more commonly, for whatever reason, in people that are of like African descent. So they'll tend to like have a patient with that ethnicity if they're going to put this into an exam question at all. And it's autosomal recessive defect in that leads to you having these like red blood cells that are like, well, they're normally normal shaped, but then they can sickle if they get deoxygenated. So if they do sickle, they become a lot more like they fragment a lot easier, and as you can kind of see in the picture that's like on the background there, it makes it a lot easier for them to like occlude small vessels, so you get these vaso-occlusive crises. So your patient can like generally be fine, but if they get exposed to the wrong triggers, so things like cold, dehydration, infection, hypoxia, the cells will sickle, and then they can clog up vessels, and you get all these kind of like quite nasty, life-threatening side effects. So generally, like, these patients have always got to be very careful that they avoid all these triggers, and these triggers are quite simple things that most people get exposed to a lot of the time, so it can be quite a hard disease to manage, and patients get hospitalized a lot. So you can be, obviously because it's autosomal recessive, you can have what's called sickle trait, which is generally absolutely asymptomatic until you're exposed to extreme conditions. So things like being in a pressurized aircraft, patients can get an anemia from that if they have sickle trait, or you have sickle state, so you are homozygous for the mutation. The one good thing about it is it does confer an advantage to infections where the host takes advantage of red blood cells, so stuff like falciparum malaria. And that's kind of why we believe it's more common in like certain parts of Africa where like malaria is endemic, because there it is kind of an advantage. But obviously, like in general life, it's still not something that you want to have anyway. So yeah, if you're gonna investigate it, if you've got a patient that, well, generally we pick up on it at birth through like cord blood sampling anyway, but the patient's going to have quite a well-tolerated chronic anemia until a sickling crisis is going to happen. And actually, like these sickled red blood cells actually give up oxygen more willingly to tissue. So even though they can have anemia, they might just never notice because that oxygen isn't offloaded with any difficulty at all. You can do something called the sickle cell solubility test to look for it, and doing your electrophoresis as well, because it's a haemoglobinopathy. So if you do HB electrophoresis, it should show up from there as well. And again, we screen for it at birth. So your sickle cell crises, there's a lot of these that can occur, and they're all occurring secondarily to like this vaso-occlusion. So your main ones are vaso-occlusive crises. Basically look for like patients that are presenting with like pain in like the digits, particularly bony pain. It can also like occur a little bit more unobviously as like mesenteric ischemia, or as like a CNS infarct or low flow priapism, but that's a bit more of a rare presentation. In kids, it tends to be dactylitis. You can get something called acute chest syndrome, which can occur in like up to about 30% of patients. Causes of that could be from infection. It could be because they've got a fat embolus that's come off from the necrotic bone marrow, or because of pulmonary embolism, because they've got these sickle cells kind of lead into a thrombus. Can present with shortness of breath, chest pain, hypoxia, and if they get them again and again, obviously it's going to cause problems with the lungs, and they can get this pulmonary hypertension, which is where you've got that. I think it's you do your right heart catheterization, and you've got mean pressure above 25 milligrams Hg. Yeah. You can get splenic sequestration, so they can get the vaso-occlusive crises occurring in the spleen, where they get this like really painful splenic enlargement. The red blood cells pool there, and it can lead to this like massive circulatory collapse, and they like very urgently need to get admitted and transfused. And a lot of deaths can occur like this way, sadly, because it's quite a sudden, quick thing. You can get aplastic crises. Again, this is one of the conditions where parvovirus B19 infection can lead to like this sudden drop in bone marrow production, leading to like an aplastic film. So again, not really something that you want, but it's not quite as bad as the other ones. It's normally quite self-limiting, only lasts for about 2 weeks, but it may require transfusion. And to manage these, obviously make sure your patient's comfortable. You're going to admit them, give them morphine, antipyretics, antiemetics, haloperidol if they're quite anxious. Make sure you've got cross-matched blood so you can give blood transfusions. Keep an eye on the blood count, reticulocyte count. Do a septic screen, especially like if infection's underlying. Make sure you're keeping them warm, hydrated. Give them oxygen if they are hypoxemic. Consider giving them empirical antibiotics and transfuse blood if you need to, but more often than not, you're probably going to need to transfuse blood anyway. A couple of the things that you can have happen were kind of like poor growth, like we were looking at with thalassaemia, like failure to thrive, stuff like that. Pregnancy problems is quite a common one as well. So like intrauterine growth restriction, preeclampsia, like the whole range of like blood-related problems. Yeah, and generally, I don't know if I said it in the other one. Yeah, your general management for sickle cell, if they're not frequently having crises, which unfortunately they probably will do quite a lot, is make sure you've got hematological input, as you should do with most of these anyway, apart from like your iron deficiency, which you can treat in GP and stuff like that. Consider giving them hydroxycarbamide if they are getting quite a lot of crises, because it could increase their fetal red blood cell production, and then it's just a bit more likely that they can kind of maintain normal oxygen without having to like it mitigates the worry. It reduces the risk of the crises. Doesn't completely cut it out, but it cuts it, because they can kind of sustain themselves on this HbF a bit better. Consider splenectomy. Transfusions are probably going to have quite a few of, particularly if they're having crises. Consider stem cell transplant, but again, like a lot of high risks to it. The mainstay of your treatment is just to counsel and educate them on the triggers and avoiding the triggers. And obviously you would do genetic counselling if you've got someone that's, say, got trait who's wanting to have a child and things like that. Cool. That is it. Hopefully that hasn't been too horrendously boring, because I know anemias can be a bit like repetitive because it's just a lot of like, oh, the red cells are down, etc, etc. I'm going to just share, I know some people have kind of dropped off as we've gone along, which is fine. I'm going to share the SurveyMonkey again. If you can give any feedback, that's great. I know there haven't been cases with this one, so sorry if it's not been quite as engaging for you, but hopefully I'll try and do some exam questions based on this and the blood cells, the blood malignancies teaching, and see how you go about with that. But yeah, if anyone's got any questions, feel free to ask. Email address in the slides, and just find me on Facebook if you want to ask anything as well. So thank you for listening, guys.